The background of why we conducted a phase 1 trial with MART-1 TCR transduced peripheral blood T-cells at the Netherlands Cancer Institute is that we know that a lot of patients, although the introduction of checkpoint inhibitors and target therapy greatly improved the outcome of patients with advanced melanoma, still a large proportion of patients show progression upon these currently approved therapies or show no durable response. So for these group of patients, a new treatment modality is necessary. Also for patients with uveal melanoma, there isn't even a standard treatment option yet, so it's very important to look at this group of patients as well. Historical trials have shown that adoptive transfer of TCR-modified T-cells has created tumor-reactive T-cells. Responses of clinical benefit have also already been shown targeting NY-ESO-1, MAGE-A3, MART-1 and GP100. And our clinical trial is set up using MART-1 specific TCR gene therapy. The clinical protocol for our trial was created at the Netherlands Cancer Institute itself, and we validated a good manufacturing practice production protocol to create these MART-1 transduced T-cells. This phase 1 trial included patients with advanced stage melanoma, so irresectable stage 3C or 4 melanoma, all progressing upon prior therapies, and there were no standard treatment options left for these patients. All patients had to have a good performance score, good LDH level, and all patients had to be expressing MART-1 on their tumors for more than 10% in order to recognize for recognition of the TCR. Patients also had to be HLA-A2-0201 positive, as recognition of this TCR only occurs in the presence of this specific HLA subtype. Patients underwent apheresis to isolate the peripheral blood T-cells, and these peripheral blood T-cells were then transduced with a retroviral vector encoding the MART-1 TCR. Thereafter, the T-cells were expanded in the presence of IL-7 and IL-15 in order to create a less differentiated T-cell product. After this, before the single infusion of this T-cell product, patients underwent a preparative regimen with chemotherapy consisting of cyclophosphamide and fludarabine. Then the single infusion of the T-cells and were seen with supportive care thereafter. The future of adoptive cell therapy is still unclear. A lot of developments have already been made, and the main thing with TCR gene therapy is to look at is to isolate a specific antigen, which is very tumor specific, but we have to look at less recognition in the peripheral tissues. Such as, for example, in our trial, MART-1 is a melanoma differentiation antigen, which is present on more than 80% of melanoma cells, which is also present on healthy tissues, such as the eyes, the skin, and the ears. So in this phenomenon, we can see on-target and off-tumor toxicity, for example, with skin rashes, dermatitis, uveitis, and hearing impairment. And it's really important to look at an antigen with more tumor specificity and less tissue specificity as well.